we should first define what is relapsed multiple myeloma and refractory. Primary refractory multiple myeloma, it's what's features here. It's non-responsive disease in patients who have never achieved minimal response with any therapy. Okay, while relapsed and refractory, its features are defined as disease that is non-responsive while receiving salvage therapy or progressive within 60 days of last therapy in patients who had achieved more than minimal response before progressing in their disease course. While relapsed multiple myeloma is defined as previously treated disease that progressed and requires the initiation of salvage therapy, but does not meet criteria for primary refractory or relapsed and refractory categories. What's the definition of treatment or whatever? We have both clinical relapse multiple myeloma and chemical relapse. A lot of difference in that. What is clinical relapse? It's the development of new soft tissue, plasmacytoma or bone lesions, increase in existing plasmacytoma or bone lesions by more than 50%, hypercalcemia, decrease in hemoglobin, a recurrent or new renal dysfunction, hyperviscosity requiring therapeutic initiation, and that's relapse clinical relapse. It needs treatment and intervention. While what about biochemical relapse? It's totally different here. It's doubling of molecular band in 2 consecutive measurements with less than 2 months. Any of the following increases in 2 consecutive measurements as serum M band more than 1 gram, urine M protein, involved free light chain more than 20 milligram per DCL, or more than 25% increase. This is what's called chemical relapse. In such cases, in biochemical relapse, if asymptomatic, we don't treat, we just follow up. We should put general considerations in the treatment of relapsed refractory multiple myeloma. First of all, it's patient disease characteristics. We should look for patients, performance age, performance status, aggressive versus non-aggressive relapse, refractory disease, bone marrow reserve, renal function, pre-existing treatments, and adverse events what happened before as peripheral neuropathy, which is the most common one, oral versus intravenous versus subcutaneous therapy, and we should look at. While components of initial therapy, we should look at did he receive any of IMiDs, proteasome, or whatever. And it's very important, we should look at availability of drugs. Strategies at relapse, how to make the right choice. Here is very important. We have 3 types: early relapse, less than 1 year post autologous transplantation; intermediate relapse, 1 to 3 years post transplantation; and late relapse, more than 3 years post transplantation. The treatment strategies at relapse. First of all, at first relapse, we should look for switch for the first treatment if the patient had before short remission, long-term treatment for long period till he getting remission, and upfront toxicity. We should switch the line of treatment in the first of all. If treatment is long remission with short duration of treatment, no toxicity upfront, here optimization with 2 drug-based versus 3 drug-based and more. Treatment relapse here. We have IMiD-based as lenalidomide, Indoxan with lenalidomide, thalidomide, and whatever, and proteasome-based. Long remission with no prior autologous, up to 3 drugs we should use, up to 3 drugs with the same initial therapy, and auto when possible, but short remission or prior auto. If the patient, in this instance, the patient may have proteasome inhibitors or IMiDs, we should 2 to 3 drugs with switch from IMiDs to proteasome, and vice versa. If prior both, if he's receiving both, we should take up to 4 drugs and consider allo if of auto not appropriate. We have many questions to ask. Do I really need to treat this patient? It's a very important question. Second question is, does the patient have new high risk features? Development of new risk. What drugs have been used so far? Response to previous treatment is very important. Efficacy, duration of response, toxicity, which is very important. How will the patient performance status and the bone marrow reserve? However, bone marrow reserve is a very important issue in such cases. What is the patient's goal preferences? Does he need IV, subcutaneous, oral, whatever? We should know that it's novel therapies lead to expand response with deeper response. This is actually history of non-curable multimyeloma in the past. We may have here, and that is the new drugs giving a change in paradigm in relapsed refractory multimyeloma. We have now first relapse, second relapse, third relapse, and even fourth relapse, which have never been before in such patients. Decision making in relapsed refractory setting, particularly early relapsed, can impact positively overall survival. Optimizing therapy in the relapsed refractory multimyeloma setting includes using broader combination than that approved. Overall evidence is insufficient to support a unique sequence of therapy. I don't have any sequence of therapy in such patient. Choice of treatment at relapse, who depends on factors such as comorbidity, toxicity, and all other things upfront, plays a major decision role. Further studies are required to determine the optimal sequence of therapy. We don't have sequence of therapy now. This is the most recent approved agent regimen as carfilzomib monotherapy, carfilzomib dexa with lenalidomide, daratumumab monotherapy, daratumumab dexa, daratumumab with puma, daratumumab, elotuzumab, exazumab, and extra. How to make the best choice for therapy? It's progressive disease while on lenalidomide maintenance, not on maintenance. We can do a triplet with RD, Regimen dexa as backbone. We can add daratumumab, carfilzomib, exazumab, and elotuzumab. While if the patient progressed on lenalidomide maintenance, we consider he's lenalidomide refractory. We should use triplet with backbone as daratumumab, VD, puma, daratumumab with KD, carfilzomib, exazumab, and elotuzumab. Future of myeloma therapy, new drugs with different mechanism of action. The disease now is a heterogeneous disease. Actually, it's not the same one. Combination may provide possible cure. Effective combination have to move to upfront setting. Early intervention may be the key for cure. This is cartoon to how drugs attacks myeloma. As you can see here, it's IMiDs or proteasome, anti-PD-1, and CAR-T. We are going to talk about carfilzomib. Is a selective epoxytone proteasome inhibitor that irreversibly and specifically binds to the effect active site of the proteasome 5 and 6. Here is the based regimen in carfilzomib in relapsed. We use 20 milligram up to 56 milligram twice weekly, and can use 20 milligram as start and then 27 milligram bi-weekly. Actually, carfilzomib, we have 3 studies. It's escalating studies. The first one is Aspire. It's very important here. Carfilzomib have been used with based lenalidomide and dexa against the standard treatment for myeloma. It's lenalidomide dexa here, and let's see here. We can see here in the lenalidomide arm, overall response was 83%, while in the standard treatment 54% in early and late relapse, while in late relapse here it's 89% overall response with almost 40% complete remission. Overall response here is in the other arm, it's 70% almost, with only 10% complete remission. In Aspire, KRD, carfilzomib, Revlimid, dexa, extended investigate to assess median progressive with progression free survival extended up to 9 months. Here's the difference between up to 9 of almost 10 months, and the overall survival here increased by almost 8 months. The second trial, it's the first one of all of the myeloma ever. It's head-to-head trial, which is it's not easy. Carfilzomib had been used in the other arm is proteasome or Velcade. KD against VD. Let's see. The Endeavor study, carfilzomib led to higher response rate in early and late relapse as well. Here in the carfilzomib, overall response was almost 64%, while in 50% in Velcade or Revlimid. In late relapse increased up to 82% with almost 15% complete response, while in the Velcade it's overall 67 and only 7% complete response. The KD extended progression-free survival by up to 8 months. Here is the difference between. And progression-free survival increased by almost a year, 12.1 months, with one prior line of therapy. So the use of second generation as early as possible is very important. And also this study, Endeavor study here, progression, it's okay, progression-free proteasome and lenalidomide, it's increased. We can see it's 15%, 15 month, 0.6 month against 8 months. It's almost doubled in the proteasome exposure, so it's no resistant in the same. If the patient received proteasome before or proteasome inhibitor, there is no double resistance here. We can use another proteasome. KD extended overall survival by 7 months. Okay, the last one study is very important actually. The use of carfilzomib, it's twice weekly. Why can we double the dose and give it just weekly almost? Yes, in weekly use of carfilzomib, let's see what have happened. The criteria for the patient, it's relapsed refractory multimyeloma, 2 or 3 prior lines, it's not one line, 2 or 3 lines, refractory the most, which is very important, to the most recent line of therapy, including proteasome or even the oral proteasome inhibitor exazomib. Let's go, let's see. Here, in the response here, once weekly, it's the response. Here it's overall response 63%. In the other arm, it's 40%. Progression survival expanded up to 11.2 months. And time to progression also increased up to 12.4. Overall survival here is not assessed because it's still up to 2 months with no 2 years with no assessment. It's very good. Overall survival at 12 months was 77% in weekly group, and almost is the same as 72% in twice weekly group. Treatment exposure here, as you can see here, carfilzomib in the dose twice once weekly. Median treatment exposure was longer in weekly group than in twice weekly group. Relative dose intensities were comparable between the 2 groups. Overall, quality of life, patient receiving weekly KD, capriolis, dexamethasone, 70 mg, reported dosing more convenient and reporting greater satisfaction compared with patients receiving twice weekly, especially in the era of COVID. We need we decrease exposure. Patients receiving weekly KD reported improved quality of life and statistically significant better results for erotic quality of life studies. So, last, we can conclude that relapsed refractory multiple myeloma treatment horizon is broadening. Actually, till 2004, we haven't any just a few treatment. Now we have many treatment up to maybe up to 20 types or lines of treatment right now, or drugs, new drugs. Combination, including new proteasome inhibitors, IMiDs, and monoclonal antibodies are giving good results. So combination is very important. Don't use in the upfront 2 drugs. We should use 3 drugs, and even in relapse, we should 3 or 4 drugs. Carfilzomib once weekly in the ARROW study combination is both safe and effective, even in heavily pretreated relapsed refractory multiple myeloma. Novel therapies will even make the future brighter. Thank you for my listening. Thank you very much.